So coming to the next question, which neurotransmitter act as a primary inhibitor in the brain? Well, the correct answer is the GABA. GABA, remember GABA, it's indeed the primary inhibitory neurotransmitter in the brain. Now it works by binding to specific receptors that are known as GABA receptors on the surface of the neurons. Now we know that the GABA, it is relieved from the presynaptic. The GABA, it's relieved from the presynaptic neurons into the synaptic cleft. That is a small space that is present, a normal gap between the neurons. The GABA will bind to the GABA receptors on the post-synaptic neurons. And remember, there are two types of GABA. One is GABA A receptors and other is GABA B receptors. Now GABA binds to GABA receptor on the postsynaptic neurons. The GABA A receptors, they are the inotropic receptors, meaning they are directly linked to the ion channels. The GABA B receptors, remember, they are the metaprotopic receptors, meaning they work through the secondary messenger. When GABA binds to GABA A receptors, it causes ion channels to open, allowing the chloride ion to flow into the neurons. The influx of chloride makes the inside of the neurons more negative and hence hyperpolarizing it. So this hyperpolarization makes it less likely for neurons to fire an action potential and thereby inhibiting the neuronal activity. Similarly, there are GABA B receptors. So when the GABA B receptors, when GABA binds to GABA B receptors, it activates the G-linked G proteins, and it can cause opening of the potassium channels, allowing potassium to leave the neurons. So that can lead to opening of potassium channels, allowing potassium ions to leave the neurons, making inside more negative. And additionally, it can inhibit the calcium ion channels, reducing the release of the neuroreceptors. So your answer is GABA receptors. Now coming to the next question, the chest compression rate in adults is, well, remember, in adults the ratio is 30:1. That means 30 chest compression are given, followed by 2 breath. Remember, in children this ratio is 15:2. So this is used when there are 2 rescuers. In a newborn, the ratio is 3:1. So the answer is 30:2. Coming to the next question, the local anesthesia with highest tissue irritant potential, it's the bupivacaine. Remember, bupivacaine is indeed associated with high risk of tissue irritation compared to some other local anesthesia. Remember, bupivacaine, it is, remember, potent, long acting local anesthetic that often require prolonged anesthesia. So bupivacaine, remember, it is more potent than many other local anesthesia. It has a longer duration. It can provide anesthesia up to 6 to 8 hours, making it suitable for the lengthy dental procedures, and controlling the post-operative pain control. While the bupivacaine, remember, it is highly effective, it has a higher potential for tissue irritation and neurotoxicity compared to the other local anesthesia. So bupivacaine, remember, it should be used with caution with the patient with the cardiovascular risk, liver dysfunction, or hypersensitivity to the amide type local anesthesia. So the main factor that you have to remember is bupivacaine long duration and high potency make it as an invaluable tool in the dentistry. So your answer is bupivacaine. FT segment elevation in lead V1 V4 of the ECG during myocardial infarction is typically due to the anterior wall. Remember, the FT segment elevation on ECG represents the period between the ventricular depolarization and repolarization. So lead V1 to V4 typically represents the anterior wall of the heart in standard 12 lead ECG. Now FT segment elevation in a lead V1 V4 is characteristic of anterior wall myocardial infarction. So that suggests the ischemia of the heart involving the anterior portion of the left ventricle, that includes the left anterior descending coronary artery. Now this artery primarily supplies the anterior wall of the left ventricle. Coming to the next question, which of one is not reabsorbed along with the sodium in proximal convoluted tubule? The answer is urea. In proximal convoluted tubule, the sodium is reabsorbed along with several other substances. Glucose, remember, it is reabsorbed by sodium glucose co-transport. Sodium and glucose are reabsorbed together in the PCT through process that is known as secondary active transport. Amino acids, they are resorbed by the sodium amino acid co-transport. Similar to glucose, sodium and amino acid, they are reabsorbed together using the secondary active transport mechanism. The bicarbonates, they are reabsorbed indirectly through the action of carbonic anhydrase. Urea, remember, it is not primarily reabsorbed with sodium in proximal convoluted tubule. Urea reabsorption occur mainly in the collecting ducts and driven by the concentration gradient rather than the direct coupling with the sodium reabsorption. So the answer is C. Which of following impression material is least preferred for pouring a definitive cast for fabricating an indirect restoration? The answer is irreversible hydrochloride. The irreversible hydrochloride, remember, they are not dimensionally stable. They must be poured immediately and are more prone to distortion and are less accurate than other materials. So that is why they are least preferred for pouring a definitive cast for fabricating an indirect restoration. The best treatment for cracked tooth with reversible pulpitis is a full crown. Well, What are the advantages of full crown? First of all, they will provide maximum coverage as well as full protection. So it is best suited for extensive cracks and for teeth that need significant protection and restoration. The resin restoration, they may not provide sufficient strength and support for tooth with significant cracks. Bidirectional splints not indicated. Stainless steel splint, they are not indicated. The best treatment is the full crown. That is your answer of choice. A hemophilic patient, a hemophilic child with gross decayed tooth require dental extraction. If the factor 8 level is 0.025 IU per ml, then severity of hemophilia is, remember, the mild, the answer would be moderate. So you have to remember, for the mild, the level is between 0.05 to 0.40, and for moderate the value is between 0.01 to 0.05. So the answer is moderate, and for severe it is less than 0.01. So your answer is B here. Coming to the next question, the Lyme disease that is also known as borreliosis. It is an infection disease that is caused by the Borrelia, and it is transmitted through the ticks. So it is also known as Van-Wart syndrome. So Lyme disease, the causative agent is Borrelia. It is transmitted through the bites of exodes ticks, commonly known as deer ticks. Now you will see a bull's eye rash at the site of tick bite. So this rash would expand over time. There will be flu-like symptoms, fever, chills, headache, fatigue. Apart from that, one may consider neurological symptoms, cardiovascular symptoms. Apart from that, arthritis, neurological symptoms that could be seen. So answer is A. Which of following these parts is responsible for declarative memory? It's the hippocampus. Remember, the hippocampus, it is responsible for declarative memory. Remember cerebellum, it is involved in coordinated voluntary movements, balance, and note the declarative memory. The hippocampus, it is important for formation, organization, and declarative memories like the fact and personal experience. So that is why your answer is B. The brainstem, it controls the basic life function like breathing, heartbeat, and it is not involved in memory processing. The basal ganglia, it is involved in motor control and procedural memory and not the declarative memory. So your answer is B here. Which amongst the following is the clinical sign of the traumatic occlusion? The answer is mobility. Well, the tooth mobility refers to the movement or looseness of tooth within the socket. So that occurs when the supporting structures of the tooth, that is the periodontal ligament as well as the alveolar bone, they are compromised due to the excessive occlusion forces, and that is true in case of traumatic occlusion. So the main clinical signs is the mobility, Mobility is the primary clinical sign of the traumatic occlusion because the excessive forces can cause damage to the periodontal ligament that can cause loosening of the tooth. Adhesion, it is due to the wearing of the tooth structure due to the tooth to tooth contact, and then it can result from grinding or clenching habits. While adhesion can be a sign of occlusal issues, but it is not exclusively indicative of the traumatic occlusion and can occur due to the factors like bruxism or with the aging. So clinical signs of traumatic occlusion, the best answer is mobility. The best prognosis for of repair among the root perforation is the, remember the answer is the apical third. Remember, the repairing in the perforation in the apical third of the root typically has a better prognosis. So the apical region, it has a better vascularity and healing potential. That is why repair is usually more favorable, allowing for the better visualization and manipulation during the repair procedure. So that is why the answer is apical third.